Okay, it's 8 o'clock. Good morning, everybody. And I'm Professor Cheah. So I'm chairing today's CPC. Today is a grand CPC, and it's by the Department of Pediatrics. So grand CPC means we got a bit of longer time. It's up to 9:30. So if you could just stay put and not go to your class, I'm sure your lecturers know that you are attending CPC if you're late. So it's going to be until 9:30. And Grand CPC also has got a special guest. And our special guest for today's discussion is none other than Dato' Zakaria, who's the chief of pediatric surgery, the ex-chief, he just retired, and a good friend of ours. So it's Dato' Zakaria. And leading the discussion will be our trainee medical officer in pediatrics, Dr. Amalina, and then Dr. Nurulhuda is a specialist who will be also moderating and taking the discussion. Dr. Nurulhuda is a neonatologist, and then we have online Dr. or Prof. Faizah, who is our radiologist, pediatric radiologist. She cannot be with us physically because she's in UIA now. So she'll be online. So it's kind of a hybrid too. Okay, I think without much further ado, I've introduced the speakers and I would like Dr. Amalina to take the stage to present the case and discuss. Thank you.
Assalamualaikum and good morning. Thank you, Prof. Cheah, for the introduction. So today I will start with the presentation of case for our grand CPC today. So baby N is a baby boy who is preterm at 33 weeks of gestation with birth weight of 1.7 kg, which is appropriate for gestational age. His mother is a 38 years old Malay lady, primary gravida, with antenatal history of in vitro fertilization in view of primary subfertility and also antenatally detected perimembranous VSD at 22 weeks of gestation. At 32 weeks and 5 days of gestation, the mother had a PPROM. Otherwise, there was no fever or contraction pain. Ultrasound scan showed a normal fetal growth parameters with AFI of 2 and placenta previa type 1B. She was admitted and treated with a course of oral erythromycin and received 2 doses of IM dexamethasone. 6 days later, she developed pervaginal bleeding, hence emergency cesarean section for the bleeding placenta previa was performed. Baby N was born vigorous with ABGA score of 9 and 10 at 1 and 5 minutes of life. However, developed respiratory distress at 5 minutes of life. He was placed on nasal CPAP and the initial chest radiograph noted to have a right upper lobe consolidation. He was then treated as early onset pneumonia and he was on CPAP for quite some time and only able to de-escalate to low flow nasal cannula at day 16 of life. Baby N was on full feeding via orogastric tube since day 5 of life, which advanced uneventfully. However, he developed respiratory distress following mixed range feeding and also direct breastfeeding at day 70 postnatally, in which he required initially non-invasive ventilation support and further escalated to assisted mechanical ventilation requiring HFOV in view of the worsening respiratory distress and also persistent hypercarbia. In which he required FiO2 of 1, MAP of 12, MT of 65, and also frequency of 12. For the physical examination, he was at that time tachycardic with heart rate of 165. Respiratory was within normal range, 45 breath per minute, and able to maintain the oxygen saturation of 99%. However, there's marked subcostal and also intercostal recession, and also lung auscultation revealed reduced breath sound bilaterally and crepitation over the right lung. The cardiovascular examination was a normal heart sound. Otherwise, the abdomen has mildly distended, otherwise and soft. Repeated chest X-ray show a right upper lobe consolidation, and at this point of time, he was treated for aspiration pneumonia and was kept nil by mouth for a few days, in which it showed improvement in terms of his clinical condition. However, upon resuming enteral feeding via the orogastric tube, his respiratory condition deteriorated. This is the blood investigation for baby N, in which it show a mild anemia with a hemoglobin of 9.5, which could be due to the prematurity and also multiple blood taking, with a reactive thrombocytosis with a platelet of 528. Otherwise, the white cell count is within normal range for this baby, which is 18, and the CRP and also procalcitonin is mildly elevated with a CRP of 1.08 mg per deciliter and procalcitonin of 0.82 nanogram per mil. So in summary, baby N is a baby boy delivered preterm at 33 weeks of gestation with a persistent respiratory distress which worsened with introduction of oral feeding. Clinically, there was reduced breath sound bilaterally and crepitation over the right lung. He has persistent hypercarbia despite on high frequency oscillatory ventilation, and the serial chest radiograph showed persistent right upper lobe consolidation. So these are further information that I would like to know to help me to further narrow my differential diagnosis, in which from the history whether there's any increase in the oral and nasal secretion, and then any vomiting associated with the feeding or coughing during the oral feeding, any evidence of poor weight gain, abnormal posturing or arching during the feeding, and also for the from the mother high vaginal swab culture and also placenta swab culture and HPE. Any family history suggestive of primary ciliary dyskinesia, such as a history of chronic cough or chronic otitis media and sinusitis. And from the examination of the baby, is there any stridor or wheeze upon the auscultation of the lung, any dysmorphic features or other congenital anomalies that would suggest bacterial association, such as imperforate anus, limb defect. And also from the chest radiograph, I would like to know if there's any abnormal vertebra, such as hemivertebra, and also any mediastinal shift. So these are the list of my differential diagnosis, in which the higher up would be congenital and also structural anomalies, such as tracheoesophageal fistula, congenital pulmonary airway malformation, and also bronchopulmonary sequestration. And secondly would be the infectious cause, necrotizing pneumonia and also nosocomial pneumonia. And also my other differential would be gastroesophageal reflux disease and also primary ciliary dyskinesia. So for my first differential, which is the tracheoesophageal fistula, my point 4 would be that for this baby, the respiratory distress is associated with the initiation of the oral feeding and also improvement upon nil by mouth, which would suggest that there's aspiration from the esophagus through the fistula and into the trachea, causing aspiration pneumonia. And the mildly abdominal distension could be due to the passing of the air from the trachea into the esophagus and gastric through the fistula. Besides that, the investigation, the chest radiograph show a persistent right upper lobe consolidation for the support the presence of recurrent aspiration pneumonia. However, my point against will be the reduced breath sound bilaterally, in which it is unlikely to happen if tracheoesophageal fistula occur alone, as it might cause reduce in the breath sound at the site of the pneumonia. However, in this patient, there's a reduced breath sound, but if there's any associated airway anomalies in which tracheomalacia is quite frequent to present with the tracheoesophageal fistula, might cause this reduced breath sound. Besides that, my second analysis would be the congenital pulmonary airway malformation. And my point 4 would be that the onset of the symptom or the respiratory distress is at birth, in which it can happen if the lesion is large, causing a mass effect and compression to the other surrounding structures such as lung tissue and also the airway. And also in terms of the examination, the reduced breath sound with hypercarbia, which can occur due to the mass effect as well, which affect the ventilation of the lung. And the chest radiograph show a persistent consolidation in a single lung lobe, which is the right upper lobe, which could be the site of the lesion. And my point against would be that during the antenatal scan, no lung abnormalities detected, which usually in a CPAM, it can be detected during the antenatal scan, and also the deterioration or the respiratory distress which occur during the oral feeding. The chest radiograph also show a consolidation instead of a cystic lesion, which is the usual presentation in a CPAM, except for in type 3 CPAM, in which it is a microcystic lesion and can be a solid-like lesion and presented with a consolidation in the chest radiograph. My differential would be a bronchopulmonary sequestration. My point 4, again, is the onset of birth. At birth, if the lesion is large, and the examination show a crepitation of a right lung, which could be due to the infected sequestered lung tissue, and also the persistent right upper lobe constriction in the chest due to the recurrent infection of this lesion. And my point against would be no detection during the antenatal scan. And also in this patient, antenatally, there's an oligohydramnios with AFI of 2, in which in bronchopulmonary sequestration, the common finding would be polyhydramnios due to the compression effect to the esophagus, affecting the swallowing of the amniotic fluid. And also the association of the respiratory distress with a feeding. And from the chest radiograph, the consolidation is set at the right upper lobe, which is not the usual site for the bronchopulmonary sequestration, which usually occur at the left lower lobe. And then my next differential will be necrotizing pneumonia. And my point 4 would be the prematurity and also the antenatal history of PPROM, in which this would be the risk factor that increase the susceptibility of this baby to infection. And from the examination, the crepitation of the right lung and also respiratory distress with quite severe respiratory distress with hypercarbia. This could be due to the necrosis and also lung tissue damage. Hence, it affect the ventilation of the lung, causing the hypercarbia. Besides that, the chest radiograph show persistent consolidation of the right upper lobe, in which there's no resolution in terms of the infection or the pneumonia. And my point against would be the deterioration following feeding. And from the blood investigation, although the PCT and CRP is slightly raised, however, it's not significantly raised, in which in the necrotizing pneumonia, the infection will be quite severe and can lead to sepsis. Hence, the PCT and CRP would be more raised, markedly raised. And the chest radiograph, there's only consolidation, no evidence of cavitation at the consolidation area, although chest radiograph is not the best modality to assess for the necrotizing pneumonia. And my next differential will be nosocomial pneumonia. Due to the risk factor, the prematurity, low birth weight, the antenatal history of PPROM, and also prolonged NICU stay, which expose the child to more infection. And then the examination, there's a crepitation of the right lung. And from the investigation, the mildly raised CRP and PCT can still be due to bacterial infection. And my point against would be the respiratory distress which occur and worsen upon the feeding. And there's no new pneumonic changes from the chest radiograph. And for GERD, my point 4 would be the prematurity itself due to the immature lower esophagus sphincter, causing the reflux of the gastric content into the esophagus and can lead to the aspiration pneumonia. And also the association with the feeding and improvement when nailed by mouth. The persistent right upper lobe consolidation further support the presence of the aspiration pneumonia. And my point against would be the onset at birth, as at that time the child still not yet being fed. And my last differential will be primary ciliary dyskinesia, in which the onset of the respiratory distress is at birth, and the inability to wean the respiratory support as the child was more than 2 weeks on a CPAP before able to wean for a short time and being intubated after that. And from the examination, there's a reduced breath sound with a hypercarbia, which can be due to the mucus plugging due to the impaired mucociliary clearance. And the chest X-ray showing a persistent consolidation over the right upper lobe could be due to the collapsed consolidation from the mucus plug. And the point against would be the association of the respiratory distress with a feeding. So from my all differentials, these are the investigation that can help me to further narrow down and also probably give a definitive diagnosis for this patient, which include the blood culture, trachea and gastric aspirate culture, which can help me to find out the causative organism and also determine the appropriate antibiotics. Upper GI contrast studies such as barium swallow, in which it can detect a reflux and also tracheoesophageal fistula if the contrast is present in the trachea as it passes through the fistula. And then the ultrasound thorax can help me to diagnose necrotizing pneumonia to look for the absent or reduced blood flow within the necrotic region, the hypoaquate region, and also pH study, which is a more accurate study to diagnose acid reflux as it measures the time or the percentage in which the pH in the esophagus is less than 4. And also from the for CT thorax or MRI thorax, it will be more helpful to identify any structural anomalies such as a CPAM, the pulmonary sequestration lung necrosis, and also the airway structural anomalies. And for CT angiograph is for the pulmonary sequestration, because in pulmonary sequestration, the non-functioning lung tissue receive the blood supply from the systemic circulation instead of the pulmonary circulation. And bronchoscopy can help to direct visualize the fistula and also can look for other airway anomalies such as the tracheomalacia. And echo to look for any congenital heart disease, as this patient antenatally has a parameris VSD, although during clinical examination normal heart sound was heard. And for the primary ciliary dyskinesia, if the other diagnosis would be unlikely, then I would proceed with the for the diagnosis of primary ciliary dyskinesia, in which the investigation needed will be the video and also electron microscopy of the cilia to look for the ciliary motion and also ultrastructure defect of the cilia. And last but not least would be the genetic testing to look for the gene that is associated with primary ciliary dyskinesia. I think that's all for me.
All right, thank you, Dr. Amalina. Just stay there, I think. Okay, so from all your differential diagnosis, what do you think? What is the more likely working diagnosis for you?
I think from
reviewing
here,
this case?
I think the most likely could be due to the tracheoesophageal fistula, due to the strong relation between the respiratory cells and also the feeding. And
Yeah, it's quite dramatic, isn't it?
Yeah.
It's immediately after the first feeding, right?
Yes, oral feeding.
So that sort of guides you towards an anatomical abnormality, you think?
Yes.
And what about the first X-ray? And the diagnosis was early onset pneumonia. The first X-ray was said to have?
Right upper lobe consolidation. Actually,
What are your thoughts on that one?
it can be due to the secretion from the esophagus, can also pass through the fistula, causing the collection or collapse consolidation at the right upper lobe.
So, but the
Although
diagnosis
no
was
fever.
early onset pneumonia. So, do you agree, reviewing the case, that it was just early onset pneumonia?
I think it's not just a early onset pneumonia, but due to the this underlying anomalies itself causing the.
But we agree that there is a risk. There was a risk, right, that the mother had leaking liquor. So it was rightful to think that there was possibility of pneumonia. But given the X-ray changes, is that likely to refer to pneumonia, or is it something that you should have thought about more? For example, congenital anomaly.
I think it will be more of a congenital anomalies, like even in the other differential for the pulmonary sequestration or CPAM can also appear to have this consolidation at the right upper lobe.
Yeah, it's very because early onset pneumonia, which I'm sure you're aware, most of the time it's more diffuse, isn't it? And this one is so localized. So do we have any information that X-ray has cleared before the incident, or not?
No,
We don't have the information. Maybe Dr. Nurul can tell us on that. Okay, Nurul, you can.
Yep, the consolidation was persistent. It did not clear between the two, between the at birth and the deterioration.
So
I think Prof. Faizah will show you the serial X-rays.
So, were there any thoughts along the way before we fed the baby?
Yes, he was actually planned for an upper GI contrast. However, he deteriorated before the contrast can be done. So at that time, what Dr.
But before the
Amalina has
incident,
not,
before the
yeah.
feeding and so-called aspiration
Yes,
incident,
because of the persistent right upper lobe consolidation. So tracheoesophageal fistula was one of the differential diagnoses, and he was actually planned for an upper GI contrast.
okay. All right, thank you. So, Dr. Nurul, you want to take over now?
Okay. So before I go into the investigation results, I will answer a few of Dr. Amalina's question, all right, regarding the history and also the physical examination. There was no history of increased oral and nasal secretion. There was no vomiting or coughing during feeding, but he was only tried on oral feeding once or twice prior to his deterioration. He was gaining weight appropriately during the first 2 weeks of life, and there was no posturing or arching noted during feeding or after feeding. And there was no family history of primary ciliary dyskinesia as well. And upon examination, at that point of time, there was no stridor or wheeze, although occasionally we noted that there was prolonged expiratory phase. He was also not dysmorphic, and there was no abnormalities that you have mentioned before, such as spinal bifida or limbs deformities. Okay. So I go into the investigation results. So his full blood picture showed normochromic normocytic anemia with occasional nucleated RBC. There was neutrophilia, some myelocyte and metamyelocyte seen. The IT ratio was 0.1. The platelets were adequate. And the blood culture and serial tracheoaspirate culture was no growth. Echocardiogram showed normal intracardiac anatomy and also function. So for the maternal investigation, the high vaginal swab and placenta swab culture was no growth. Placenta HPE showed evidence of chronic villi maturity in relation to gestational age, which appears, some appear edematous. There is also mild degree of neutrophilic infiltrates at the subchorionic region, and areas of microcalcification with foci of fibrin deposition are seen. So the diagnosis of the placental HPE was acute subchorionitis, maternal inflammatory responses, stage 1 and grade 1. So now, Dr. Amalina, I'm going to show you the ventilator loops that was seen when the patient was actually ventilated on patient-triggered ventilation with VG of 6 mL per kilo. Okay, would you like to see again?
Yes.
So for the students, this is what we call the pressure volume curve, if you remember your physiology. Yeah.
This, okay. Would you like to describe the abnormality seen?
Can I see again?
Oh, okay.
Okay, it is pressure volume loop, and from the picture, it is a pressure control, and however the expiratory limb, the volume is reduced, which could be due to obstruction of the airway, causing the reduce in the expiratory, and I think there's some air leak because the expiratory limb does not return to the baseline.
Okay. You said there's a reduce in the aspiratory here.
Yeah.
Is it the flow in the flow volume
Yes.
loop? Okay. All right. Okay. So that we can appreciate the normal pressure, normal graphics of the ventilator as well.
Sorry, Dr. Nurul, can you, or maybe Dr. Amalina want to comment on the pressure volume in terms of the loop itself? What do you think, Amalina? Oh, the answer is there.
Sorry.
Yeah. Amalina? So the loops are really open, isn't it? So that tells you that the lung is compliant, a very good expansion.
So this is the normal graphics, all right? That's the pressure volume loop, and that's the flow volume loop. Okay, so this is the patient's ventilator graphic. So as you can see, the pressure volume loop has become more round in shape, and indicating that a higher pressure is required to overcome the resistance to reach the target volume. Okay, so you can compare this two loops. And apart from that, you can see there's a significant flattening of the inspiratory and expiratory flow volume loop. So what you expect to see is a rapid rise in the flow volume loop during inspiration, okay, followed by a slower phase, all right, until the end of the inspiration. And then as the expiratory valves open, the pressure will the flow will go to the opposite way and rapidly, and then subsequently reduce to the PEEP level at the end of the aspiration. So this do not occur in this patient, where you see a significant flattening of the inspiratory and also the expiratory flow volume loop, indicating there's a fixed large airway obstruction. Okay. And apart from that, you can also see that the patient did not receive his tidal volume. Okay, so we set the tidal volume at 6 mils per kilo. At that time, it was 12 mils, but he only received about 4.4 mils. Okay, so now,
Dr. Nurul, so for the students, you see, if look at the left, the normal graphics, that's how your pressure volume curve is going to be normal. That's how it looks like. So memorize that. That's how it should look like.
all right, so now I would like to invite Associate Professor Dr. Faizah to update us on the radiological investigation findings.
So before Prof. Faizah tells us about it, Dr. Amalina, Dr. Nurul actually mentioned about echo examination, cardiac examination. What in particular would you like to see in the cardiac? I think it was not one your differential diagnosis. That's why I'm asking you. We did an echo. What would you want to look for?
Any associated cardiac congenital heart disease, which related to esophageal fistula, such as VSD.
Besides that,
And then if there's any abnormal aortic arc that could be causing the obstruction, causing a vascular rings.
yeah, in what, for example, things like
Right aortic
pulmonary artery sling and all that, which can actually go around the tracheal and esophagus area, which could actually cause that type of right upper lobe collapse consolidation as well. So that is one of the differential that I think you didn't give. Yeah. Okay. All right. Prof. Faizah.
All right, Prof.
Thank you for joining us online.
Okay, good morning. Assalamualaikum. Thank you very much, Prof. Cheah, for the for accommodating Prof. Cheah, Nurul, and also Amalina and the admin of our CPC for accommodating me. I'm sorry I couldn't be there physically, and thanks literally for the pediatric department for this invitation. So I have the chest radiograph at birth. So maybe Amalina, you want to give your comment?
Okay, this is a chest radiograph of this patient. However, I think it's at birth, no dated, but then the view supposedly is a AP view because in a neonate. Okay, so from the chest radiograph, I could see that it is hyperinflated with posterior rib of 9 ribs, and then there's opacities over the right upper lobe and also actually right middle and perihallar region. From here, I couldn't really see any deviation of the trachea, and the heart does not appear to be displaced. No cardiomegaly seen. I couldn't see any bony abnormalities such as like hemivertebra, and no like pleural effusion or pneumothorax seen.
So what would be your differential diagnosis at this point based on what you have given the information earlier?
So I think the differential that could be narrowed down from this chest X-ray could be the tracheoesophageal fistula and then the pulmonary sequestration or CPAM itself.
Okay, thank you, Amalina. So the chest radiograph actually show hyperinflated lung. I mean, you correctly mentioned it earlier. And then there's an opacity in the right upper lobe. So we could actually represent the consolidation. But at the same time, when you look at the intercostal space, you can actually see that there is a reduction in the volume between the right and the left. If you compare between the two, that means there's some element of volume loss. So that means there is some collapse consolidation. Of course, we go for a common things first. So that means the most common would be a aspiration pneumonia as a differential, top differential. And we have to exclude common cause, which is the gastroesophageal reflux disease or H-type tracheoesophageal fistula. So your thought flow earlier was very good. Okay. And please, I just for the sake of the medical student and also MOs, don't forget the lines and tubes. Okay. I just want to highlight, at the same time, I just want to show that there is also timers because it is it is not opaque as the consolidation. And we know that at this age, the timers is still big. Okay. So just to highlight about the lines, especially the nasogastric tube. So the ideal position of the nasogastric tube should actually be understanding that the tip, and we also have a side holes. And the side hole actually present just near the tip of the NG tube. And it should be located somewhere between the gastroesophageal junction here and also the pylorus somewhere around here. Okay, so we do not want the side hole especially to be more proximal, and thus it can actually cause an iatrogenic aspiration pneumonia. Despite patient does not have any GERD, but because of your NG tube position, then you have actually introduced a aspiration. So another thing to ponder is that, of course, the more obvious one, which is the position of the nasogastric tube has gone into the lung, for example, in this case. And this is an example of that the tip of the gastric tube is in the position, but the side hole is actually in the distal esophagus. So these kind of cases are the one that will introduce an iatrogenic aspiration pneumonia, and you do not want to contribute to that. Okay, so just make sure that the side hole at least about 10 centimeter beyond the GE junction, you can actually postulate and count that. So this was the radiograph that subsequent from this child, day 8 of life, day 15 of life, but we still see that there is persistent right upper lobe bronchus as mentioned by Dr. Nurul earlier. So we did an ultrasound thorax at day 16 of life, whereby ultrasound is the state of art in pediatric radiology. So we'll be able to see, this is the thymus, and the character of the thymus is that it looks like quite a big soft tissue, especially in neonates, but it does not cause any compression to the vessel. So for example, this is the left bronchocephalic vein that crosses from left to the right into the SVC, but yet you do not see any compression this part of this large soft tissue. And on the right side, if you see, there's some soft tissue here. Compared to the left side, we don't see any. So this is how an airfield alveoli should look like, but in on the right side, we do see that there is loss of the airfield alveoli more proximally here. So then we know there is actually an element of right consolidation. So this is a more higher resolution of the same area, just to show how different is the echogenicity between the thymus and the right upper consolidation. So a serial radiograph actually show that the right upper lobe consolidation starts to clear up, but the thing is, it's still persistent. You do see some residual interstitial opacity in the right upper lobe here. And you do notice that previously the child was not intubated, but now patient is already intubated. And with the pressure ventilation, that they had problem in adjusting the pressure. So therefore the child had a CT thorax done at day 30 of life. So the initial referral to us is that they want to exclude, the neonatologists want to exclude large airway obstruction. Okay, so this is the scene of it. Let me just show. This is from posterior. You're actually seeing, from the vertebral body. So this is the vertebral body. And then what we are seeing is that first the airway. I just want to show you the airway. So this is the trachea, and as you can see that distally it starts to narrow, and it's quite a long segment of narrowing, and it seems like it has also affect the proximal left main bronchus and the right main bronchus. The child also had residual consolidation or granular spasticity here in the right upper lobe, but there's also a new left upper lobe consolidation, and that means, aspiration is very high on the list. However, there's another findings that is quite surprising to us even. So because if you follow, this is the right upper lobe bronchus. So this is the right upper bronchus. It should actually originate from the right main bronchus. So instead, it actually traverses posterior to the right upper lobe right main bronchus, and then it communicates inferiorly with the esophagus. So this is the nasogastric tube within the esophagus, and you can actually see that the airway, the right upper lobe bronchus actually goes and communicate with the esophagus, and it does not have any communication with the right main bronchus even. So this is just a static film of it. So that's the right main bronchus, but yet we're seeing the right upper lobe bronchus actually communicate with the esophagus. You do see the diagnosis already, but I will show you after that. Okay, so this is the post-processing, the minute. So what we see, what we do is that we enhance the lucent area which contains air, and then we accentuate it and become looks like a 3D formats. And what we can see is that the tracheal stenosis again, the airfield tracheal stenosis, that also affect the narrowed proximal right main bronchus and the left main bronchus. And so the only branch that comes from the right main bronchus is the bronchus intermedius here. Okay, so by that we should see right main bronchus and then the right upper lobe bronchus, but yet this right upper lobe bronchus actually traverses posterior to the right main bronchus and into the esophagus. So this is the axial of it. So just to show you the right bronchus intermedius, and the right upper lobe bronchus is actually traversing posterior and does not communicate with the right main bronchus. This is the lateral image of this, the sagittal image of this child, CT. You can see that the tracheal stenosis, and that's the crina, just to show the length of the tracheal narrowing. So what we have here is that there is a right upper lobe bronchus that directly communicate with the esophagus, no communication with the airway. We do not see any systemic blood supply direct from the aorta that can suggest pulmonary sequestration. We do not see any pulmonary sling to suggest any external compression of the large airway. And the patient also has the congenital tracheal stenosis because the narrowing is actually circumferential. And of course, no external compression by anything. So what we have here is that we concluded that this child actually had a communicating bronchopulmonary foregut malformation. So in our case is that here we have particularly one segment, an isolated segment that communicates directly to the esophagus and does not have any communication at all with the airway. So this is a type 3 communicating bronchopulmonary fistula malformation. And of course, in this patient, which is very rare, has an association with congenital tracheal stenosis. So the CBFM itself is rare, and with the association with congenital tracheal stenosis is even rare. Okay, so I'll be back soon. Back to you, Nurul. Thank you very much.
Thank you, Prof. Faizah. Just again, for the clinical students, the preclinical students who are supposed to be attending, that is a very nice illustration of embryology that goes wrong in the development, causing this anomaly. Yeah. Okay, thank you, Nurul.
Yeah. Can I please share my slides here?
While waiting, any burning questions from the floor? Okay. Oh.
Dato', I have a question regarding the chest X-ray. Prof. Cheah, you mentioned about early pneumonia. It's consolidation localized. Then you wouldn't think about aspiration pneumonia first, or just early pneumonia. And Prof. Faizah described the chest X-ray, and she said the differential diagnosis is aspiration pneumonia the first. So that's my question. And when you have that kind of pneumonia, for the benefit of medical student, what trigger you to proceed with CT scan rather than just treating the patient and do serial chest X-ray and see how the patient progress?
Thank you, Prof. Dekan. No, I think what we're saying is the baby came up with so-called early onset pneumonia. That was a diagnosis because the mother has leaking lipo and all that. So they think of infection. But what we're saying is, in the setting of infection, you shouldn't have a very nice upper lobe collapse consolidation. So if it happens so early, you start to think whether there's a congenital anomaly causing that, especially if it's persistent, which I think Prof. Faizah has shown. And the reason why we don't think of aspiration first is because the baby was not really fed immediately. So I think that rules out the aspiration, and you have to think of a congenital anomaly to give that feature on the X-ray. Thanks. Prof. Dekan is also an airway expert, so any other comments on it?
Okay, can I just add? Thank you, Prof. Cheah, for that information. Of course, you need to think about congenital lung malformation whenever you see a pre-existing lung lesion. And of course, to us, we go for a common differential as well. So that's why it goes hand in hand. But just that normally the sequestration and should actually be at the lower lobe, the common location. So I'll go for common things first. So so that's why we have an added differential of aspiration pneumonia in our differential.
Yeah.
Actually, as what Dr. Nur mentioned, that we plan for upper GI study because we have a H-type fistula top in our differential, but the thing is, patient is not stable, and we were referred because of the large airway obstruction indication rather than because of we want to assess the right upper lobe problem. But instead we see surprises during that time. Thank you.
Since you bring it up, thanks so much, Faizah. If let's say you review the X-rays and you usually give comments, right? If you have seen that, would you have flagged it for us and say, look, think about these anomalies?
Yes, I would. I would give both. Congenital lung as well as aspiration.
Yeah. Okay. Thank you.
All right, so I'll update on the progress of the patient. So it's a male infant, moderate preterm AGA with persistent right upper lobe collapse consolidation since birth. So he was intubated and ventilated at day 17 of life. Ventilation was challenging. He had persistent respiratory acidosis despite various ventilation strategies, which include high frequency oscillatory ventilation and also conventional ventilation with volume and pressure guaranteed. So CECT thorax on day 13 showed complete tracheal ring with small and right left main bronchus, mid to distal tracheostenosis, and also communicating bronchopulmonary foregut malformation with right upper lobe hypoplasia. So he was referred to the National Multidisciplinary Cardiology and Respiratory team and was planned for multi-stage surgical repair. So he underwent the first operation here in HPKK, in which right open thoracotomy and right upper lobectomy was performed on day 55 of life. So the surgery was difficult as there was no clear transverse fissure for lobectomy and the fistula was not able to be identified, and upper lobe was resected based on the reduced aeration and also the ischemic changes. So feeding was resumed post-operatively via nasogastric tube, and he achieved full feeding day 7 post-operatively. So despite that, he had recurrent desaturation and persistent respiratory acidosis. So during desaturation, he had copious amount of secretion with markedly reduced aspiratory breath sound and also biphasic stridor. He required high PEEP to keep the lower airway opened. So a series of radiological investigations was performed to investigate his condition and also to re-evaluate prior to the next operation that is planned for him. So back to you, Prof. Faizah.
Thank you, Nurul. Okay, so this is the subsequent radiograph, chest radiograph that was done after the CT. This was done at day 38 of
Sorry,
life.
Prof.
Can you hear?
Encik Zaki, can we have Prof. Faizah? Thanks.
Okay. So we still see there is a residual interstitial opacity in the right upper lobe, which and again I want to highlight that the ETT is actually quite high here, and we already flagged because the fact that it should actually be at the T2, T3 level. If it is high, then it is very easy to have a self-extubation for the child. Okay, mind you that the child had a tracheal congenital tracheal stenosis at the same time, so just beware. So with this, subsequently three weeks down the line, you can still see some interstitial opacity. Child is still intubated, and you do see a compensatory hyperinflation of the lung, most likely related to the airway obstruction. So this was the post-operations chest radiograph immediately after. So you can appreciate that there are areas of there are chest tubes, and then there's a surgical clips here that goes along the oblique fissure anatomy, and you do see there's a reduction in the volume in the right upper lobe. And subsequently, this was the radiograph that was done a few weeks after that. Okay, so because of the persistent symptom, and the main question was to exclude whether is there any how does the fistula anatomy looks like post-operatively. So we did a second CT scan at day 94 of life. What we see is that there is a collapse, focal collapse consolidation in the right upper lobe, which looks slightly smaller in terms of the volume. So that consistent with the lobectomy, but we concluded that this could actually be a partial lobectomy because we can still see the right upper lobe bronchus here. As we traced it, it goes along the course that what we saw earlier on the first CT scan. However, we are unable to see the direct communication. So this is the esophagus with the nasogastric tube. We are unable to see the direct communication as what we saw on the first CT scan. So just to show you the mediastinal setting of it, so that's the surgical clips, and we do not see any hematoma or any granulation tissue that can compress the airway or even the fistula itself. Again, the small trachea and also the small proximal right membrane bronchus. So what we have here is that the patient actually had a persistent right upper lobe bronchus, we are unable to see the connection between the right upper lobe bronchus and the esophagus. And of course, the child still have the tracheal stenosis. So because of this problem, so we proceeded with an upper GI study at day 104 of life. And this was the imaging. So what we did is that we parked the tip of the nasogastric tube at the mid of esophagus, and we injected contrast and while taking the picture via fluoroscopy, okay, the fluoroscopy machine. So what we see is that we do see that there is a direct communication from the esophagus itself, and it opacified the right upper lobe bronchus immediately. And therefore, there is still a communication between the right upper lobe bronchus with the esophagus, as what we thought. Now, so that's the static images of it. So we do, this is on the coronal or the AP view, and this is on the oblique lateral view. So you do see the esophagus, and then this is the right upper lobe bronchus that also opacify the alveoli distal to that. So she had a persistent right upper lobe bronchus communicating with the esophagus. So this is my last slide. Just want to show that our role after this, the second CT was to make sure that the child being fed very well via a nasogastric tube, or rather a nasojejunal stomies tube. So we inserted via fluoroscopy, administered the tube more distally, and we want to make sure that the tip of the nasojejunal tube is actually part more towards proximal beyond the pylorus, so that the child can be fed very well, and thus would not have any risk of aspiration at any time. So so that was my my last slide. Thank you very much. Back to you, Nurul.
So, as Prof. Faizah has mentioned, CECT thorax was repeated at 3 months old, and there was the right bronchoesophageal fistula with upper lobe bronchi. The tract was not completely seen to be communicating, and there was also a complete trachea ring with reduced right lung volume. And upper GI fluoroscopy revealed patent bronchoesophageal fistula at the level of T7 and T8. So nasoduodenal tube was inserted and continuous feeding was resumed. So following the insertion of nasoduodenal tube, his condition improved with reduced episodes of desaturation. At about 4 months old, he self-extubated and was placed on non-invasive ventilation support. So during insertion, he had soft audible inspiratory stridor, but the breath sound was good bilaterally. So he had no more respiratory acidosis with PCO2 of about 55 to 65 millimeter mercury on capillary blood gas. So his ventilatory support was successfully weaned to nasal CPAP. He was then transferred to Hospital Sedang at 4.5 months old for further management of his condition. So now I would like to invite Dr. Zakaria to present to us the update on the patient and also the surgical management done there.
Assalamualaikum and good morning. Thanks for the invitation from Peace Department to talk on the management of this patient. Actually, I'm not supposed to present this because I'm retired, so I should be happily enjoying life. Unfortunately, the person who's supposed to present is away on leave. So, things have to move on. Okay, at the end of the all the investigations, we knew that this child had a dual pathology, basically a tracheal stenosis in the lower half of the trachea and a communicating bronchopulmonary foregut malformation. The combination of which is very rare. This is the first I've ever encountered in my almost 32 years in pediatric surgery. I've seen quite a number of tracheal stenosis, obviously. Even in CBPFM, the esophageal lung, the ones that we've seen are mainly in group 1, which are the ones associated with tracheoesophageal fistula. We've seen 2 cases, but interestingly, the previous 2 cases, they were from the lower lobe. So basically, this is the first case that I've seen in the country, and I think reported even worldwide, that the connection from the bronchus is actually from the upper lobe. So Faizah mentioned this about the classification of the grouping. Obviously, this patient had a group 3. The difference is that in this picture, it's basically from the lower lobe. In the case here is from the upper lobe. So what we have here is trying to manage a patient with a dual pathology of tract stenosis. This was the bronchoscopic findings just before the surgery. The length of the stenosis was not very long for a child who's about 4.5 months old. And obviously, the decision would be, how do you tackle this? So we look at the literature, and there's been, till this report in 2012, 10 cases of basically CBP-FM associated with tracheal stenosis. And interestingly, obviously in the first few years, many of these babies died. And if you look at the ones underlined, the Japanese have decided to basically transect the bronchus and reimplant it back into the trachea. Most of these cases are basically the group 2, which means that the right main bronchus actually is connected to the esophagus. Actually, if you end up removing it, you will end up doing a complete right pneumonectomy. So because this right upper lobe was a bit hypoplastic, in the end we made a decision that probably is not worth the effort, because obviously trying to anastomose a small bronchus to the trachea is extremely challenging. So the decision was made from the start that we will do a stage surgery. Actually, the plan initially was to do the first stage in HUKM, and there was the attempt in removing that, but I think there was so much difficulty. So when we discussed this, eventually in Sedang, we decided to do the slide tracheoplasty first. Slide tracheoplasty is basically surgery for tract stenosis on 9th of December, and then followed by the right upper lobectomy for the esophageal lung type 3 via the same posterolateral thoracotomy about a week after that surgery. So some information on tract stenosis. The incidence is about 1 in 30 to 100,000 live births. I think in Malaysia we probably see about 5 to 7 cases per year. Obviously, there's no Malaysian registry as far as I know. There's a wide spectrum of presentation, and majority of this are actually associated with cardiopulmonary anomalies, the so-called vascular ring complex, vascular sling complex, and basically a left PA sling is the most common, where it basically constricts the lower trachea. Isolated tracheal stenosis is rare, and as mentioned before, tract stenosis associated with CBP-FM is quite rare. I think Faizah has shown very nice CT scan pictures. There are many, many variations of this tracheal stenosis, and you need this in order to plan the surgery. I don't know whether UCAM has this facility. I think this was from a patient in IJN, where you have a dual source CT and you can really do a very good airway reconstruction. Here is even rarer. You actually have a bifurcated trachea, which presents similar to a tract stenosis. Eventually, nothing was done for this baby, and eventually the baby died. So the next investigation is basically a bronchoscopy, in which you are able to see whether the tracheal stenosis is localized, in which you see a very short level of stenosis, or it's a long segment. And this information is basically combined with that of the CT scan in order to define the anatomy. Now, do all tract stenosis require surgery? Actually, the answer is no. There's been quite a number of babies who we decide to observe, and many of these actually outgrow the symptoms. So if you have acute life-threatening episodes, or the inability to extubate a baby who has tract stenosis or recurrent emissions, prolonged need for NIV, then these are the babies that require this surgery. And obviously, if a cardiac surgery is needed for any of the cardiac abnormalities, cardiac TOF, PA sling, obviously when you do this, the concern is that post-surgery, because of the tracheal stenosis, you may not be able to extubate these babies. So in general, if you have a cardiac abnormality, and a PA sling, the current treatment is that you must do both if you have a tract stenosis. And this is the unfortunate thing, because many of these babies may not be diagnosed with tracheal stenosis before the cardiac surgery. Now, tracheoplasty surgery for tracheal stenosis is a true multidisciplinary teamwork. It requires a huge number of people, and obviously it's high-risk surgery with definite risk of mortality. And obviously surgery should be done only for those cases that really need the surgery. And it's very labor intensive. So you need a high level of commitment from all the members of the team, from pre, intra, and post-op. So a huge list starts from everybody in pediatrics, from respiratory specialists, radiologists, cardiologists, ENT surgeon, because post-op, many of these babies require bronchoscopies, and obviously cardiac surgeon, ped surgeon, the whole works. Now the question has always been asked, why did I get involved in slide tracheoplasty? I'm basically a pediatric surgeon. I shouldn't be doing all this work. Worldwide, these are usually done by pediatric cardiac surgeons, because obviously when you do all this cardiac work, it makes sense for them to continue doing the tracheal work. Unfortunately, many years ago, when this happened, there were very few pediatric cardiac surgeons. And obviously most of their work has been in the critical cardiac cases. So the problem was that you do see isolated tracheal stenosis. And these are the ones that have difficulty getting into the system. So I got involved because no one seems to be doing it. And things just move from there. But by the time I retired in 2022, a pediatric cardiac surgeon started doing the work in Serdang. So I backed off, just gave some advice over the phone, sometimes in OT. But unfortunately, that peds cardiac surgeon retired before this case was done. So I had no choice but to go back. So surgery is like, you can check out, but you can never leave. So we've done 23 till the time I retired. I think there were a few more cases done in IJN and in Serdang after that. And obviously these are all done in centers with pediatric cardiac surgical expertise, from Serdang to IJN to UMMC. We did one in Penang. We can do this without needing bypass if it's very localized. So we've done 3 cases in HKL or HTA. And of the 23 cases we've done, 7 have died. I think including one from UKM many years ago that went to UMMC. So the planning of the surgery on the 9th, obviously it has to be done at GA, supine position, and the approach is always median sternotomy because it needs to be done at cardiac bypass. The reason why you need to do a cardiac bypass is that the endotracheal tube will have to be removed while you do surgery on the trachea. So technically, you can either do this under bypass, or in some centers, they actually do this under ECMO. In this country, I don't think we've ever done any pediatric cardiac or airway work under ECMO as yet. So the principle of tracheoplasty is that you basically transect the trachea at the center of where the stenosis is. So after you transect, you get 2 ends of the trachea, and then you cut in different directions. So one on the anterior wall and one on the posterior wall, and then you slide them together. I mean, the term slide exactly means that. So at the end of the surgery, you do shorten the trachea to some degree, and the trachea may be as short as almost a third of the original length. Now, interestingly, if you try and do this surgery in adults, you will have trouble. Good thing about infant trachea is that it's fairly flexible. So you're able to pull and you're able to anastomose, even untensioned, without the problem of basically causing a leak like you do in adults. So usually it starts with the airway assessment, as we did for Haris, basically to define the anatomy just before the surgery. Sometimes the airway becomes normal, not obviously in this case, but it looks more Malaysic than stenotic. So in those cases, surgery is abandoned, and it has happened before. And we place the endotracheal tube just above where the stenosis is in order to define it better at the time of surgery. You must remember that the trachea is a very solid structure. So you will not be able to palpate, and you will not be able to see much of the difference in terms of the normal to the stenotic area. So the cardiothoracic team will start first, do the median stenotomy, put on bypass, and do whatever cardiac op that's necessary. In Hari's case, there was none. And then the slight tracheoplasty will be done by, at the moment, the ped surgery team with the help of the cardiac team. And once that is done, you will reverse the bypass and close the chest. Now, basically, what you need to do is basically get access to the trachea. And if you imagine the anatomy, the trachea is further back. So you need to free the thymus. And as Prof. Faizah mentioned, the thymus is a fairly large structure in a neonate. So that needs to be removed. And you'll be able to see the trachea by using basically the innominate vein, left brachiocephalic vein, as a marker. So you may need to free it as long as necessary, depending on what is seen on bronchoscopy or the CT scan. And usually distally, you need to go to the carina. So once you've done that, the edges of the trachea has to be mobilized, because in order to slide it, obviously it needs to be freed from the surrounding structures. You do not want to free it too much, because obviously there is a risk of devascularizing the trachea if you do that. And during this time, the ETT is still there. So once mobilization is done, we then do a flexible bronchoscopy. The reason is to define where is the definite proximal level of stenosis. Because as I mentioned, looking at it with naked eye is very difficult to be certain. So you need to look from inside and define that. And once we see that, we actually place a needle. So the needle will go into the lumen that can be seen from bronchoscopy. So that will define the proximal level. So once that is done, we then remove the endotracheal tube, and the slight tracheoplasty then begins. We need about roughly 45 to 60 minutes for the repair of the trachea. So this is where we put the needle in order to define the proximal level of the stenosis. And once that is done, we cut midway between the stenosis, between the needle and basically the carina, because most of this stenosis will extend all the way down to the carina. And in Hari's case, we thought that it extended right down to the bronchus. Okay, so once done, you have two ends of the trachea. So one is done, we need to further dissect in order to get the length. And this is where the slide comes in. You cut the trachea in opposite planes. So you can either cut it anteriorly on the distal trachea and posterior on the proximal, or vice versa, depending on how you feel comfortable in joining them together. When we did this, actually when we looked at Hari's, the left and right main bronchus was not as narrowed as what was seen. We actually calibrated it with endotracheal tube, and we decided to basically leave that alone. So once that is done, you literally attach them together and close them with interrupted suturing using basically a long-acting monofilament. So the end results, if you look at this, these are the two ends. When you join them together, it becomes either a figure of O, or most of the time, sort of an 8. So you try to make it as O as possible, but sometimes it's not, it's very difficult. So as long as this doesn't happen, it doesn't overlap too much like this, I mean, this is not ideal. You should have something that is really round. so that there's no resistance to airflow. So once that is done, you need to check for the problem of leaks. And this is where we do a bubble test. It's similar to how you repair a bicycle. Okay, you just basically take over ventilation, and you have to intubate. Before doing that, you have to do another flex bronch, and this is where we railroad an endotracheal tube. And the purpose of this is to also remove whatever blood and secretions in there, and basically checking for the size for the reconstructed trachea. So this railroaded, the question whether use a microcuff or an uncuffed tube is very much the preference of whoever the anesthetist is at that time. I don't personally have any objections to either. And the other thing is, where do you place the tip of the ETT? Personally, I'm quite happy to just place it on the carina, even on the suture line, because I think it's quite safe. And this is after that you do the bubble test, and then you basically reverse bypass and watch for the lung expansion and saturations. And after this, you may still need to do further bronchoscopy in order to do bronchial toilet. So basically, closed chest, sent to ICU, you can start feeding as early. In some of these babies, you can actually extubate them early. In some centers, you actually extubate them on table. So you don't have to worry about this. But obviously, there is a risk that you may need to do suction. It's more difficult. And post-op, do flexible bronchoscopy as per needed. It's even safe to do at POD1. The trachea is not like esophagus, where the presence of the scope inside may disrupt the anastomosis. I don't think there's been any evidence that doing a flexible bronch on a reconstructed trachea causes an anastomotic leak. So this was his chest X-ray at POD1. Obviously tubes everywhere. By the time POD6, before we did the second stage surgery, everything had cleared up. And actually by this time, the child was ready for extubation, but because we decided to carry on with the second surgery, which is basically the CBPFM surgery, this was done a week later. And this is the esophagus on the sling. And this is where the bronchus was. Okay, so we managed to track that, basically transect here, close that with non-absorbable sutures, and remove the right upper loop. And the anatomy is that, as mentioned, the pulmonary artery and vein of the right upper lobe was supplied as per usual. Basically, it's not a sequestrated lung. Now, if you look at CBPFM, again, they're not very common. The last review that systematic review looking at this in 2019, 61 cases, and interestingly, worldwide, the most common is a group 3. I always thought it was a group 1 associated with TOF, as it is in this country. But worldwide, it seems to be group 3, and the mortality rate of all these cases is up to 13%. So what happened to Haris post-op was that he obviously needed multiple flex bronchs post-op, mainly for bronchial toilet, and he was extubated to CPAP at POD10. And basically the nasovaginal feeding was continued. I tried to convince the RESP that it was quite safe to start nasogastric feeding, but unfortunately I lost the battle. So the child was discharged home last week after 43 days post-op at the age of 6 months, going home for the first time on home CPAP and nasovaginal feeding. So what will happen to this child? Basically, most of the tract stenosis, usually we can wean down from the home CPAP by about 3 to 6 months post-op. They do need for some time because obviously there will be some degree of tracheomalacia after the repair, and by then the risk of recurrent chest infection should be low. I've not seen any acute life-threatening episode 6 months and over post-slide tracheoplasty. So in the long term, they do very well. And as I mentioned, in terms of feeding, by the time the child comes for review in another month or 2, we should be able to start at least nasogastric feeding. The concern that I have is that some of these babies actually do develop oral aversion. because they've not been orally fed for a very long time. And in some of this, actually we've had to resort to doing gastrostomy, which I think is a shame, because the earlier you feed, obviously the better for this child. So this was one of our earlier cases of tract stenosis that was done in IJN. It was done when he was about a year old in April 25. Now he's 11. He's like any other normal child. And the good thing is that he's now even able to swim normally. So, he's trying to show off that his trachea is really, really good. So, at the end of the day, I think tract stenosis is a surgery that is very worthwhile doing. Even though it's complex and the high risk of mortality, the long-term quality of life is extremely good. Thank you.
Thank you, Datuk Zakaria. I hope this would have inspired a lot of budding surgeons here. You realize that students, you need to have a good grasp of anatomy and embryology if you want to be a good surgeon. So those preclinical students who are attending, study well your anatomy and embryology and apply it. And as you can see today, Datuk Zakaria has illustrated nicely. Just a quick question. You were saying about how, how probably complicated it may be to do the tracheoplasty. Is there any situation where you need to put a graft where you cannot pull, to anastomose?
I think in the past, most of this were done via a patch tracheoplasty using basically pericardium or even costal cartilage. The ones that we did in HTA were basically very localized. So we actually harvested a bit of costal cartilage and basically put it there. But interestingly, in the States, there is an ENT surgeon. He's probably the only ENT surgeon that I know who does basically thoracic tracheal work. And he does most of this basically through a neck incision, the cervical incision, which means that most of these trachea are quite flexible. You can literally pull them out. With proper retraction, you can pull them out and basically do the slide from the neck. I think the way to go in most of this is actually to do this under ECMO. I've been trying to convince anybody who wants to listen to me to do this under ECMO because I think that's the way to go. Obviously, bypass has its own issues. And obviously, ECMO, you do it mainly if it's an isolated, like in this case. If you have something that needs cardiac surgery, obviously you need to do it under bypass. We've actually done one in UM, a child with cardiac cough with tracheal stenosis. And the child was on bypass for almost 8 hours. So we were worried about the state of the brain and the spine and all that, but the child pulled out very, very well.
Sounds good.
So it's interesting that how this plasticity of the brain in the child makes you able to do all these things. I doubt whether you can do this in adults.
All right, thank you, Datuk. Dr. Nurul, you want to continue with the discussion and to wrap up? We've got about 20 minutes more.
Thank you, Datuk, for such an insightful and interesting presentation. Okay, I'm just going to summarize very briefly on bronchopulmonary foregut malformation. Right, so we already know it's a rare congenital anomalies rising from faulty separation of trachea and esophageal tissue during embryological development. So this malformation include a wide variety of anomalies, which include pulmonary sequestration, foregut duplication, cyst, and also diverticular of the upper GIT or pulmonary tree. And if a tract is preserved between the respiratory and alimentary system, it is known as a communicating bronchopulmonary foregut malformation. All right. So different studies have showed variation in the relative number of bronchopulmonary foregut malformation in the population. As you can see, tracheal stenosis is one of them, and it is very rare. In this series, only one case of tracheal stenosis were reported among 203 patients with bronchopulmonary foregut malformation. All right, so a bit on embryology, all right. At the 4th week of gestation, the tracheal bronchial bud develops from the foregut as a diverticulum surrounded by the splenic mesoderm, right. At the 5th to 17th week of gestation, the laryngotracheal tube will develop, followed by 2 lung buds and progressive branching of the pulmonary tree, eventually forming a blind ending terminal bronchioles. And segmental bronchi are formed by 6 weeks. So from the 13 weeks onward, respiratory bronchioles and primitive alveoli will form, so that gas exchange is possible by the 24 to 25 weeks of gestation. And at term, the alveoli is about 1/6 of the adult number. And this will continue to, the lung will continue to develop until about 8 years of age. So bit on the etiology. So this was actually suggested by Clemens and Warner, unifying theory that can explain all the major bronchopulmonary foregut malformation, in which the early bronchial buds are actually supplied by capillaries from the primitive systemic circulation. As the lung grows, the vessel regress and the pulmonary artery supply becomes dominant. So interruption of this process at different times and sites during development will result in varying abnormal development in the affected area of the lung. So for example, a complete arrest of the pulmonary artery supply and arrest of early bronchial development will result in agenesis of a lung, lobe or segment, while a localized interruption of blood supply with continued distal development of the lung tissue will then result in tracheal bronchial stenosis or bronchial cyst. So CBPFM, which is a communicating bronchopulmonary foregut malformation, is often related to esophageal atresia and tracheoesophageal fistula, pulmonary sequestration, cardiovascular anomalies, and also vectoral association. And it also can involve any lobes, most frequently unilateral whole lobes or lower lobes. So our patient has actually have a rare abnormalities in which the communicating bronchopulmonary foregut malformation was associated with the upper lobe. So as Dato and Prof Faizah have mentioned before, our patient had a group 3 congenital bronchopulmonary foregut malformation, in which an isolated part of the lung is communicating with the esophagus. So this bronchus is also known as an esophageal bronchus. So the combination of CPFMs and congenital tracheal stenosis is an extremely rare congenital abnormality with so far I think 11 cases were reported in the English literature. Okay, so often patients will present with respiratory insufficiency soon after birth and recurrent or persistent pneumonia. So if you guys remember, that is what had happened to our to the patient that we have discussed earlier. So there will be a persistent opaque hemithorax or opacity at the affected lobe with ipsilateral mediastinal shift on chest radiograph. And on standard barium swallow, we can actually diagnose the fistula or the communication between the gut and the respiratory system. So for all congenital tracheal stenosis, ultra-thin slicing CT scan and fiber-optic bronchoscopy is essential. So when they are diagnosed at the same time in early life and the affected lung seem to be preservable, an elaborate therapeutic plan should be considered. So Takamizawa and colleague has described a case of esophageal lung with CTS in which multiple step approach was performed, which include forced endotracheal intubation, bronchotracheal anastomosis for the CPPFM, and subsequently tracheostomy to stabilize the airway, and lastly slight tracheoplasty. And in this case, the ipsilateral lung function was successfully preserved. Right, so these were the series that was shown by Dato earlier, in which all the patients had esophageal lung, and almost more than half had an associated esophageal atresia and also tracheoesophageal fistula. So in 4 of the cases, bronchotracheal anastomosis was performed, and in one of the case, concurrent slight tracheoplasty was performed, and the patient actually survived with a functioning affected lung. So it is a rare condition, and the outcome depends on the associated malformation and early recognition. The clinical presentation and diagnostic workup is similar to that of other CPFPMs, with the addition of special attention to the tracheal stenosis. All right. For the benefit of the medical student here, I will talk briefly on the pattern recognition approach to diagnosis of neonatal lung disorders, focusing on the focal lung disorders. Okay, so there's a wide spectrum of disorders may affect the lungs of the neonate. So the chest radiographs are the primary imaging modality used in most cases. So interpretation of neonatal chest radiograph can be challenging because many diseases produce similar imaging findings. Using a systematic pattern approach, one can narrow the differential diagnosis and provide essential information critical to the clinical decision making. So the most common imaging technique used is, of course, your chest radiograph, and most neonatal lung disorder can be diagnosed and managed with radiographs alone. So in selected scenarios, for example, when you suspect a congenital lung malformations or cardiovascular abnormalities, cross-sectional imaging may provide essential additional clinical information, and CT is indicated. So ultrasound thorax is rarely used. It has a limited benefit in diagnosing neonatal lung disorder because of the acoustic shadowing of the air in the lung. However, it can be used to evaluate a pleural effusion or an aberrant vascular supply as seen in pulmonary sequestration. So this is actually a good approach in diagnosing a neonatal lung disorders. Okay, the first step is to determine whether the neonate is a preterm or full-term neonate and whether the findings are diffuse or focal. So in the interest of time, I'm going to focus on the neonatal lung disorders that presents with focal or diffuse or focal neonatal lung, focal or diffuse or focal lung changes in the chest radiograph. So focal lung disorders, basically the changes are more specific and then the diffuse disorders, and imaging plays a central role in their diagnosis. Conditions in this category include a congenital lobar overinflation, congenital pulmonary airway malformation, and also bronchopulmonary sequestration. So what is congenital lobar overinflation? Is hyperexpansion of a lobe of the lung, often resulting in mass effect of the adjacent structures. And it is due to narrowing or weakness of lobar bronchus causing a check valve mechanism. It's most commonly occur in the left upper lobe. All right. And your prenatal ultrasound may show hyperexpanded hypoechoic lobe. So in the immediate postnatal chest radiograph, you would see retention of fetal fluid within the affected lobe because there is a delayed clearance of fluid from the affected lobe. However, in the subsequent chest radiogram, as the fetal fluid is being absorbed and the lung is being aerated, you would see a progressive lucency and hyperexpansion of the affected lobe. So next is your CPAM, or previously known as a congenital cystic adenomatoid malformation, which is a abnormally formed lung tissue with bronchial overgrowth and also arrested alveolar development. So it can be found in any lobe, but it is most commonly located in the left lower lobes. And fetal ultrasound showed heterogeneous hyperechoic lesion, which may contain cysts of various types, various sizes. So there are actually 5 types of CPAM. Yeah? So the typical finding of CPAM on a chest radiograph is a solid mass of soft tissue density, which may contain air or fluid-filled cysts. And a large lesion will produce mediastinal shift to the contralateral side with compression of the adjacent lung. So this is a right-sided type 3 CPAM. You can see a solid mass here with a soft tissue density, all right, with small cystic lesions within the solid mass. So next is the bronchopulmonary sequestration, which has been mentioned quite frequently during this presentation. It is a focal lung lesion composed of malfunctioning lung tissue that is disconnected from the bronchial tree and has a systemic arterial supply. So there's an intralobar and extralobar bronchopulmonary sequestration, right? And intralobar, usually they have they shares the same visceral pleura to the adjacent lung, while extralobar they have a separate visceral pleura compared to the adjacent lung, and they also usually usually drain into the venous systemic venous drainage. So it typically again occurs in the lower thorax, and in the prenatal ultrasound you can see homogeneous hyperechoic mass with Doppler imaging showing an anomalous arterial supply from the aorta. Alright, so the most common appearance is if it's an intralobar, you can often see a loosened area as fetal fluid lung clears and air enters. If it's an extralobar bronchopulmonary sequestration, it will remain dense as what you can see in the chest radiograph here, as there is no communication with the normal lung. Right, and on your ultrasound Doppler and subsequently contrast enhanced CT angiography or MR angiography is often indicated to better define the arterial and venous supply of the bronchopulmonary sequestration. So next we go to the lung disorders that can cause both diffuse or focal lung changes. All right. So the condition that comes into this category include your neonatal pneumonia. All right. I think everyone is familiar with neonatal pneumonia. All right. And then your pulmonary interstitial emphysema and aspiration in the setting of congenital anomalies such as your tracheoesophageal fistula or esophageal bronchus. So I'm going to talk specifically on aspiration due to congenital anomaly, which occurs when there is an abnormal communication between the esophagus and the airway. For example, if there is a H-type TOF, proximal TOF with distal esophageal atresia, or when there is an esophageal bronchus in which an anomalous bronchus originates from the esophagus. So this is what had happened to our patient. Okay, so they often
Sorry, Nurul, I think you need to wrap up because we passed time.
Okay, all right. This is actually my last slide. So changes, you would see a focal or diffuse pulmonary opacities, all right, and you can even see a malposition nasogastric tube or oral gastric tube in the chest X-ray. So in summary, understanding the imaging findings in various neonatal lung disorder is essential for optimal patient care. Although the imaging findings in many neonatal lung diseases overlap, one can use principle of pattern recognition to arrive at the correct diagnosis and plan for appropriate management strategies.
Thank you very much. So I think we have a very extensive discussion today. And very much appreciated that Dr. Zach has actually shared a very extensive experience on this very intricate problem, a very rare problem too. We have discussed a lot about the embryology and anatomy. And I think Dr. Nurul has taken you a very good summary of what we should be looking at in terms of a neonate with a persistent lung disorder. I think what we need to remember is, a baby presenting with a lot of secretions at birth. You have to think whether there is any airway anomaly as well. And the first thing that we usually do in that situation, you put the Rouse tube in and see whether it coils up or not. Because if it does, it tells you something like esophageal atresia with these anomalies that may be present. The other thing is, if you see an X-ray and you note there's a right upper lobe collapse, it's not easy because, like Dr. Zach said already, usually the thymus is in the way and may give you the impression there's a right upper lobe collapse. But if in the event that you're not sure, you can do an ultrasound to see whether, is it the thymus or is it the right upper lobe? And if it is the right upper lobe, it's very likely there's an underlying congenital anomaly. So do not just think that this is pneumonia. Of course, you must think pneumonia which is treatable, but you must also think whether there's underlying anomaly or not. So those are the red flags when you see an X-ray in a newborn with a right upper lobe collapse, consolidation, or opacity. So I think with that, I want to close this CPC. And thank you, Prof. Dekan, to be here. I actually have a lot of questions to why ENT could or could not have been involved in this because, yeah, okay.
I want just to say something very impressive work, Dr. Zakaria. And I agree that managing lower tracheal stenosis, especially in the thoracic region, is not easy. And we don't have many surgeons, or specialists in the country who can do. And Dr. Zak mentioned about the United States. I think what Dr. Zak mentioned is in Cincinnati, there are ENT surgeons, Robin Cotton, Mike Rutter, who does tracheoplasty by neck incision. So for medical students, you may be thinking like, why the pediatric do not do tracheostomy? Like they always remember upper airway obstruction, do tracheostomy. But we are dealing with low tracheal stenosis, and doing tracheostomy wouldn't bypass that stenosis. So having a virgin, pristine trachea is pertinent for the success of kind of surgery that Datuk Zak mentioned just now, tracheoplasty, and that's the way of managing. And it's impressive how the surgery can make the patient survive, and have a very good quality of life. So for tracheal stenosis, I do more of adult, and ENT does a lot of open surgery, right, resection and anastomosis in neck region. But when it comes to trachea in the thorax region, we need help from the cardiothoracic pediatric surgeon. Yeah. And the mortality risk is very high.
So when you need to open the chest, obviously you need the cardiothoracic surgeons and median stenotomy to approach the lower trachea. Yeah. Okay, thank you very much for all your participation and students to attending this, and faculty who has given a fantastic discussion. Thank you very much for attending. Thank you.
All
Have a
right.
good day.
Medical student, you have your Kahoot session, right? Yes.
Yeah, medical students, please do your Kahoot. You win the prize,
Okay.
Okay.